Hello, everyone, and welcome to another episode of the Overcoming Chronic Illness podcast. My name is Dr. Brian Rade, and I am a naturopathic doctor. And today I am very excited to be joined by Dr. Alexis Goth. Dr. Goth is a medical doctor here in beautiful Halifax, Nova Scotia area. I think she's technically in Bedford, like I'm technically in Bedford, just outside of Halifax for folks that aren't familiar with the area. And I'm excited to talk to Dr. Goth because she's just a wonderful clinician, wonderful human being. We have co-managed several patients together over the years, and she has a background in functional medicine. In more recent years, to my understanding, she's been working with different types of substances to help folks with different mental emotional challenges, things like ketamine-assisted therapy and other analogous tools. And so I think that's going to probably make up the majority of what I'm going to ask her about today, but we'll see where the conversation leads us. As per usual, my interviews tend to be quite free flowing, and we just take it where it may go. And so, anyways, we're really looking forward to speaking with Dr. Goth today. So it's been a long day, so forgive the mush mouth here. As I said, we've known each other for quite a while, and she's just really genuine, very good-hearted clinician, a human being, credit to our species. So I'm really looking forward to having a chat with her today. We don't really communicate that often because we're both really busy, but on the occasions that we do have to communicate, it's always a pleasure. So I'm looking forward to having better part of an hour with her today. Just before bringing Dr. Goth into the conversation, if you haven't already, please consider signing up for my newsletter. The link to do that is either in the show notes of the podcast, if you're listening to this on a podcast platform, or it's in the description below the video if you're watching this on YouTube. The advantage of signing up for the newsletter is that every once in a blue moon, you'll hear from me. I don't send newsletters out very often. I will not bombard your inbox with newsletters. And of course, I don't sell your email address to any third parties or anything like that. But in those newsletters, I just talk about things that I'm excited about in practice, kind of new things that are on my radar, maybe things that have been on my radar for a while, and giving updates on those things. I always try to stay on the cutting edge of all the newest, latest, and greatest things that are out there, therapeutic tools and tests and all that good stuff. Also, if you sign up for my newsletter, you get complimentary access to the first two modules of my Overcoming Chronic Illness course. That's a course that I designed to help patients or caregivers of patients to navigate the sometimes confusing and treacherous waters of complex chronic illness. So I cover topics like Lyme disease, co-infections of Lyme, mold illness, mast cell activation syndrome, mitochondrial dysfunction, intestinal issues, and other things like that. So you get access to the first two modules for free. And if you watch those and you're like, oh my gosh, I'd really like to do the rest of this course, then it's available for purchase over and above that. If you're interested in my newsletter, please consider signing up. Otherwise, I am going to pause the recording and I'll be back in just a moment with Dr. Goth. All right, everyone, I'm now joined by Dr. Alexis Goth. Dr. Goth, thanks so much for taking the time to chat with me today.
Thanks for having me, Brian. Awesome.
My pleasure. I've been looking forward to this. We've been trying to pin this
Me
down for
too.
a few months, so I'm glad we got finally have a chance to chat. Would you mind just telling listeners just sort of who you are, where you practice, how you kind of got to this point in your practice career?
Sure. Okay. So my name is Alexis Goth. I was trained as a family physician at Odell Housey in Halifax. In a nutshell, I ultimately was working a lot, was really stressed. I was up north with a really big practice. I became sick myself I'm not totally sure what the clear diagnosis would be, but some type of inflammatory, very diffuse multi-system experience, we'll call it. I didn't actually see another physician, so I'm not clear exactly what it was, but it led me into a more holistic lens. Invited me to look more kind of globally at what was happening in my body. And then I went from that experience into integrative medicine. And then from there, got really curious about functional medicine and then got really curious about a lot of things. And then ultimately, kind of in my late 30s, early 40s, explored psychedelic assisted medicine. So I've been weaving all like my favorite things together for the last, I'd say 8 or 9 years now.
Awesome. That's great. Yeah, it's
Yeah.
nice to
Yeah.
like have that winding journey because the more, I think pools that you dip your toes into, then, or fully submerge yourself in, as it might so happen,
Yes.
then yeah, you just become a better and better, more well-rounded clinician. So it's awesome. Um,
Yeah. Thank
so
you.
so would you be able to just give listeners like if they're like, oh, I've kind of heard of psychedelic medicine, or I know what a psychedelic is, and I know what medicine is, but like, what is psychedelic medicine? Could you just kind of give us an overview of like what that involves, what kind of agents might be used, that kind of thing?
Sure, sure. So I guess kind of to rewind, like in the 1960s, late 1950s, there was with the development of LSD, which is one of the early psychedelics, there began a lot of research at that time on psychedelic medicine and really like, what is this? And I think the word psychedelic itself means mind or soul revealing, right? So they were recognized as compounds that are either classic compounds, classic psychedelics that are found in the natural environment, or synthetics that allow us to see ourselves and experience ourselves and our soul self in a very different way. And so, historically, if we shoot back really, really deeply and far into, First Nations people and Aboriginal people who've been using plant-based medicines for what's believed to be tens of thousands of years. So there's long-standing history of shamanic use of plant-based traditional medicines that would have psychedelic effect, that were used ceremonially, that were used in preparing for a hunt or a battle, or just preparing the community. So then in the 1950s, really good research, really interesting stuff happening with the psychedelic movement, but also psychedelics were being used culturally. And there was an explosion of psychedelics in the 60s that ultimately, I think, was going so far that the powers that be at the time thought, okay, this is too much. We've got to shut this down. And so psychedelics at that time were made illegal, they were criminalized, and all the research on psychedelic medicine was stopped at that time. So the psychedelics that were in play, I would say in the 60s, mescaline, which comes from, I believe, peyote, if I'm right to think that, 5-MeO-DMT, which can come from the Colorado river toad, LSD, which was manufactured at the time, and lysergic acid that was produced and made psychedelic, and then psilocybin in magic mushroom, which again, widely used in Central America, Mexico, and then was kind of brought to the recognition of people during that time and then used more widely here as well.
So what kind of agents are used nowadays in psychedelic
Yeah,
medicine, or I guess and maybe just like broad spectrum, like in across the board, what's still used in
sure.
let's say more of like a medicinal or medicalized sense, shall we say?
Mhm.
And then what are you using in your own practice, or what do you have experience with?
Sure. Great question. So there's still the classic psychedelics that are still in use and still being researched now. So I should kind of fast forward. So in late, I believe it's like late 1990s, Johns Hopkins University began reemerging some of the research, and they were using psilocybin. So mushroom research has been going on. There's ongoing LSD research. Um, and then ketamine, which is a dissociative anesthetic that has also been developed in the early 60s, has gained a lot of popularity. And that's been researched as I guess, a legal access psychedelic, a pharmaceutical psychedelic, if you will, that's been used for the last, almost 30 years, more research robustly since the late 90s. So I would say most of the main ones that we're considering when we think of what's happening in the psychedelic movement right now would still be mushrooms, LSD to a certain extent, ketamine, and also MDMA. I don't know if you're familiar with MDMA. It's categorized with the psychedelics. It doesn't create a change of state that the other psychedelics would, but it has gotten a lot of attention through MAPS and the research coming out with treatment for PTSD.
MDMA, is that closely related to ecstasy?
Yeah, it would be like exactly in the 80s, kind of like press pills, ecstasy, has a street name, can refer to as Molly, and was, at that time again, offering really good relational therapeutic benefit to people. And then ultimately it was also categorized and made not available and has been criminalized. And so there has not been a lot of research up until the MAPS organization in the United States really kind of decided, okay, we'd like to understand this more. And they've been pushing it through FDA, approval through the research they've been doing for some time.
Hmm.
Yeah.
So as far as all those different agents that are available, like is there I don't know, is there a so they all fall under the umbrella of psychedelic medicine?
Hmm.
Certain agents, like you kind of mentioned MDMA, maybe for I think you said PTSD. Am I
Hmm.
question that? Or there is kind of like, oh, if you have X, Y, or Z, mental health condition, we'd be more likely to use X, Y, or Z, A, B, or C psychedelic agent. Like, do you kind of match up like that, or is it more just preference of the clinician that's administering it, or how do you know like which psychedelic agent to use for a given patient?
Yeah, that's a really good question. I don't think the research is there yet because again, there was such a gap in the research. There was such a time when none of this research was happening, and then it was really anecdotal or underground work that was maintaining the use of psychedelic medicine. So I don't think we're at the space now where we can definitively say, okay, this agent is probably the best for this condition. But I think we'll get there. I think as hopefully the decriminalization movement is happening and as more clinicians can access, and we'll talk about that, like what is the legal access of psychedelic and what can we engage with, then I think we'll have more clinical experience that we can learn from our clients as well and then make better choices. I would say, but what is known about MDMA, because it doesn't adjust your perceptual appreciation of reality as much as the others can. If you're somebody who has a lot of control, which I have a lot of compassion with, because I definitely have a lot of desire for control in my environment. If people identify as having trouble relinquishing control, or they need a lot of control, or they have a trauma-based experience where they feel control has brought them safety, and this is why the PTSD can be really significant, they tend to be better served by agents that don't really necessarily fully distort their environment. Because in those states, you're not out of control, but you're no longer really in the driver's seat of what's happening. Yeah.
And I very much appreciate your use of tactful use of language there, Dr. Goth. And I'm just gonna just come right and say like so, like someone's using say LSD or peyote or ayahuasca or something like that. It's maybe going to be a little more like, oh, like the walls are melting, or I'm seeing whatever, like certain like things that aren't there with MDMA, or I think insinuating that there's not that kind of like distortion of reality in the same way. It's more just changing the way that you're perceiving reality but not actually distorting it. Is that fair, or am I off base there?
Yeah, no, I think you're totally right. I think with MDMA, it's a felt experience, it's an emotive experience. There's definitely a sense of connectivity through what we consider a love emotion or your own heart. It's very felt, it's very physiological. There's a lot of physiological activity with MDMA, and yet your visual experience of reality, of how it looks, is intact.
Mhm.
It looks the same.
Right.
Where just like you named, and I apologize to ayahuasca. I forgot I haven't mentioned ayahuasca yet, but ayahuasca is like the mother. She'll strike me down, but she's of course like the mother, kind of like the queen of the what are considered classic psychedelics, and of course, huge long history of use, South American use. But yes, in those because it contains DMT, so dimethyltryptan, so DMT, ayahuasca, LSD, I believe peyote as well, will have very strong visual perceptual changes. Salvia would be in that category where it's so different that it eyes open, eyes closed, you can be having a very different visual experience of reality, and it doesn't turn off right away.
Mhm.
So that can be, extremely beneficial, but also extremely destabilizing if someone's not really prepared for that or ready for that.
Right. And I guess
Yeah.
just one little side question, not really a medicalized question. I'm just curious. I mean,
Sure.
I've heard like people talking about their accounts with, say using DMT and then also like ayahuasca. And my understanding is with ayahuasca, where I believe you said that, ayahuasca contains, there's a DMT component there. Whereas with ayahuasca, to my understanding, it will be like a, hours, sometimes many hours long experience. Whereas with DMT, to my understanding, folks are just using DMT on like straight DMT. My understanding is it can
Mhm.
feel like a very, very long experience, but it only lasts in reality for I think minutes or something like that. So I'm just if I have my
Exactly.
okay, I do have my facts right
You
there.
do.
So what's
Yeah.
the difference there? It just kind of seems a little bit. There must be more compounds in the ayahuasca than just the DMT, I guess. Is that the idea?
Yeah, exactly. It's a brew of two plants that are put together, and the combination of the two plants together is prolonging the effect of DMT
Right.
once it's ingested. So it's not being broken down
Mhm.
in the stomach. And so there's that prolonged, typically a 3 to 5-hour experience of the DMT versus DMT that's typically inhaled or smoked, which is really profound, incredibly beautiful experience, but brief,
Hmm.
more like a 15-20 minute experience.
Right. Okay.
Yeah.
And then just in terms of like what can be accessed in Canada, let's say, and
Sure.
maybe we'll say US too if you happen to know about that, because I know a lot of
Yeah.
listeners are from the US and other parts of the world as well, but we'll leave it to North America.
Sure.
So I mean, I know like I've heard of folks having ketamine assisted therapy, maybe some like psilocybin assisted therapy, and then I just don't really hear about folks, at least in this neck of the woods, like accessing the MDMA.
Mhm.
So I'm just wondering, is that but am I just or LSD for that matter, am I just not
Mhm.
talking to the right people, or is that something that's harder to access in these here?
Yeah. No, you're right on. You're right on with that. So it's kind of curious how all this is coming about. So maybe we'll start with the psilocybin. So really, the legislation around medical assistance in dying, from what I understand of the history, when the legislation was passed in Canada for MAID, there was lobbyists who were recognizing the benefit of psychedelic medicine and basically approached the government and said, look, we agree that if you are allowing legislation for an assisted death in Canada, then you should be open to legislation for allowing a relationship with a plant, a fungus, and is that not okay? And it was enough of an argument that I think it began an opening under what was called at the time Section 56, and it was a mechanism by which people would apply through Health Canada to have an exemption that they could access psilocybin, which is the psychoactive ingredient in magic mushroom. And it was working, and people were getting access to magic mushroom. Now, over time, that has shifted and changed. There's a group, Theracil, that I'm associated with in British Columbia, and they're an amazing, amazing advocacy group. And through their work and other people working alongside them, really have been pushing this forward in Canada. Where it stands right now, there is a special access program through Health Canada. That program is typically one that, say, if someone was had a cancer diagnosis and wanted to access special access to, say, a chemotherapy that is still under maybe research, maybe it's not made its way through legislation, and maybe it's not been available to everybody, then you could apply to the special access program for that medicine. So we've been using the special access program to apply for medicinal mushroom. And there are a lot of, stipulations of who can and cannot get access, but typically it's been folks with refractory depression. So they have had a major depressive disorder that's diagnosed. They have tried multiple modalities, typically 5 or more pharmaceuticals, and it's demonstrated that nothing has improved their status and they're really clinically unwell, or they have end of life distress palliative care, or they're palliated, I should say. So you can understand that's not everybody. And those, in my opinion, or my experience, were the only people that we were having access for. But very recently, through the group Theracil and through their advocacy, they have been bringing these arguments back to the Supreme Court and saying that folks should have access to this medicine. And I understand that there was a decision a couple of weeks ago where the court did say that Health Canada was being obstructive and that they should allow more access to mushroom. And I believe the person in question had a cluster headache. So it's a new diagnosis. It's very optimistic. It's really exciting for us to hear that maybe more folks we can get this medicine for. Your question on MDMA can also be accessed through the Health Canada pathway. It similarly is really tough to get. It's refractory PTSD, from what I understand, is the access point at this time.
Hmm. Okay.
Yeah.
And what's the story with ketamine? Because that's one I seem to hear the most
I
about.
mean, yeah, my favorite little baby, my new baby.
Uh-huh.
Ketamine's fascinating. Ketamine's fascinating. So I'm a physician. I've worked in the I still work in the hospital system. So ketamine we use prolifically, I should say prolifically, but regularly in the hospital. And it's been in use for probably into its 6 decades. So we have a lot of experience with ketamine. It's a dissociative anesthetic. So it's used by anesthesia. It's used in chronic pain settings. It's used in palliative settings. My experience with it would be more in the emergency room when we're using it for, reductions and people who've had, acute trauma. Um, but we understand that ketamine has some really interesting properties, and it allows for not just a dissociation for the anesthetic, but similar to other psychedelics, you can dissociate and get past parts of the brain structure called the default mode network that I'm curious if you tap into this with the work that you're doing with the brain mapping, but that it can allow us a sense outside of our habituated nature. That research began emerging, I believe, in the 90s, where it was understood that folks that were getting ketamine for unrelated events to their mental health were recognizing that they were not as depressed or the depression was lifting. And since that time, there's been a lot of curiosity. Can ketamine be treating these mental health conditions? It has these psychedelic properties, and thus far, it's not been criminalized. So it's been one that we can access more readily.
Hmm. That makes a lot more sense now. So thank you for
Yeah, if that makes sense. Yeah,
it
it's
does.
kind
Yeah.
of it's like the new kid on the block, but it's not really a new kid. It's just always been available. It's a pharmaceutical. In it's we can legally prescribe it and utilize it. I always say for now, because I'm always curious what's going to happen with ketamine, but for now we can.
Good. Yeah. And actually, just one little nerdy side question here, because I'm
Yeah,
aware of it, for, of course, the psychedelic medicine properties, but then also for the pain management properties. I work with a lot of folks with chronic pain, and I'm just wondering, like, just
right.
dosage wise, or like, is it like what differentiates, like, oh, we're using this for pain, we're using this
Yeah.
for psychedelic medicine. Like, is it a different dose? Are you administering it over a different period of time? Like, how do you get different effects from that?
It's a really great question. So ketamine is working, and I like the dorky questions. I'm really dorky, so I love kind of getting into it this way. Ketamine works through a lot of receptor systems. It's mostly working to block the NMDA receptor system. So it's an inhibitory property through NMDA, and that seems to be allowing that dissociative mechanism.
Mhm.
But it also is working through weak kind of opioid receptor systems, calcium receptor systems. It's altering gene expression where there's acute and chronic pain involved. It seems to be working through the kinase, then like mTOR pathways. It's working through like altering kind of glutamate metabolism and how that might, offer changes as well. So there seems to be effects in the immediate effect. It's cleared very quickly. Its half-life is actually really quick, but it seems to have this prolonged effect that we're just, again, understanding it more and more. But to your question, like when we think of like typical use in the hospital, say for pain, we might be using 25 or 50 or maybe 100 milligrams of IM or IV ketamine. And that is similar to doses that I would be using at the beginning of someone's experience. For a psychedelic experience, when I'm offering someone ketamine, I start with half a milligram per kilogram. So that might be 40 or 50 milligrams. And typically they're fairly intact. They feel kind of like themselves, but they know that something's happening. But once you get into the 1 milligram per kilo, 1.5 milligram per kilo, then we see more reported these, significant states of, you know, expansion where they feel not like themselves anymore. There's a relative loss of observer or what we'd call like subject object observation. Like that gets lost, the sense of otherness gets lost. I don't know if you're familiar with the mystical experience questionnaire,
No, no,
the
what's that?
MEQ. Yeah, it's a great questionnaire. It's like a 30 question that's been used in the psychedelic research for many years, mostly with mushroom, but it's asking people who are utilizing a psychedelic how they're beginning to feel about themselves, reality, divine, and it's trying to capture these experiences because they're really challenging to describe. When people come out of an experience, like how do you just, we're not prepared to describe that. They tend to be wordless. They tend to be, we don't have the language to really capture what just happened. But people definitely have sense of a loss of self or a dissolution of ego is a common thing that's being expressed. And we tend to see that at the higher doses of ketamine. And similarly, at higher doses, I would say, of all psychedelics.
Okay. And I'm just wondering, like in terms of side effects, like just kind of hearing like, okay, so ketamine's used for, anesthesia, and there's, um, I have not looked into the research literature on this, but I've heard through the
Yeah.
kind of like, we have to be a baby careful where there's some, rare but still, meaningful incidents of like, even say marijuana use, like especially in an, not yet fully developed brain, like, maybe triggering schizophrenia
Hmm.
some people. And I'm just wondering, like, in terms of the safety of this, like, of course, there's risk with anything in life. Crossing the street can be dangerous given the certain circumstances. But just wondering, like, are there any safety factors that are of particular relevance with psychedelic medicine?
Yeah, I think that's a really good question because it's as they're being researched more and they're looking at the function of what psychedelics are doing, and then they're comparing that to what's happening in functional MRIs with people, say, for example, with psychosis, there is similarities happening, right? So with the psychedelic medicine, it is allowing the witness a sense of self that is outside of how it would typically see itself or see themselves. And there's words used like there's a boundless sense where or we feel divine or we feel godlike or we feel that we're not, in body. And depending, I mean, who's telling this story, if someone has schizophrenia, they can be reporting sometimes these same things. It's, in our kind of checklist when we're listening to someone who may be suffering from schizophrenia. I would say the difference is when someone is schizophrenic, unfortunately, they lose the capacity to reconcile the experience they're having with consensus reality. And they may have had that experience spontaneously, or it may have been drug induced in their case. So if we get a sense that the client themselves has a personal history of kind of losing touch or an expanded state of reality, or they have a direct first degree family member that's happened to, then we would definitely be cautious with these agents because we know that it's probably working on the same levels of the brain. And again, this is not totally understood. It's certainly not. This is an evolving area of research, but it would be enough for me, certainly if I was a clinician, to say, look, there's other ways that you can enter a non-ordinary state. You can enter it through breath work, drumming, spinning, dancing, rhythm. Holotropic breath work is actually a really great way in. And those are much more easy for the client to control and participate in versus you've taken a substance that you may then be in an altered state for. I mean, ketamine is very brief, but some of the other ones, for example, like acid, even mushroom, a macrodose of mushroom can be a 5 to 6 hour experience. That can be a lot for somebody
Mhm.
and potentially dangerous if somebody has that predisposition.
Mhm.
Yeah.
Um, just have a random question that came to mind, so I
Yeah.
just typed it out here. I've heard some folks talk about using sensory just when you're talking about like, drumming and dancing and stuff, it's like,
Yeah.
yeah, get into altered states using sort of psychedelic means. And just in terms of sensory deprivation tanks, I've heard some folks who have, had experience with psychedelics and also use sensory deprivation tanks saying that I can get to like the same place sometimes, doing
Yeah.
that type of thing. I'm just wondering if
Right.
therapeutically, like in your clinical experience or otherwise, if you've had any, well, first, second, or third hand experience with
Yeah.
sensory deprivation tanks kind of playing a role and like having a therapeutic effect potentially.
Yeah, it's such a great question. I've myself, I'm somebody who expands really easily. I've learned that about myself. So I tread really lightly in these spaces, and it's given me a tremendous amount of respect for these medicines. So I've not gone into a sensory deprivation space because I know I would definitely get into an altered state. So I've not used it clinically either. But I think it's fascinating because I think what it's showing us is again the way that our cognition is set up, and again, this default mode network. So the default mode network is essentially there are regions of the brain that we know are in this functional connectivity we talk about. And that connectivity is this baseline, although dynamic, it's not stuck, but a baseline mode that allows us to feel separate and distinct and a sense of like where I end and someone else begins. And a tremendous amount of our sensory information that's coming in through our five senses is stabilizing this and keeping this intact. Okay. So I think when we remove our senses, specifically with the sensory deprivation tanks, like right even down to your body temperature, because the water is matching your body temperature. So you really get a sense of you don't know where your boundary is anymore because those cues have been removed. By definition, you're in a boundless state. And I think it allows probably something happening internally with the default mode network to become much more fluid. Yeah. The work around the default mode network is why we think psychedelics is working because, or maybe one of the reasons they're beneficial. Because if I, for example, were to get into a really negative self-image or self-talk, imagine if I'm in a depressed state I mean, some folks are in depressed states we know for years, and they're thinking becomes fairly contracted and rigid and I'm by no fault of their own, kind of they fall into patterns that become quite limiting. These patterns can become much more fluid and dynamic in a psychedelic state, and they may be given the opportunity to see outside of the pattern.
Mm.
And then we've got all the neuroplasticity that can happen after the psychedelic experience, which is really where it's so beneficial. We try to integrate what people saw or experienced during the state. And now, how can we apply that, what they saw or experienced or found out about themselves, into their regular everyday experience?
As you keep talking, Dr. Goth, I keep thinking of more
Yeah.
questions here because I
Yeah, that's
eventually want
good.
to, I
It's
eventually want
great.
to, it is, it's handy if when you're interviewing somebody to keep having questions coming up. Um,
Yeah.
I do want to eventually circle around to like just asking what the actual experience is like for a patient who's
Yeah,
going through this. But just I have a couple more random questions here. Just where you
of course.
mentioned neuroplasticity, which is on my
Yeah,
mind all the time. I mean,
all
hopefully
the time.
all the time
Me
in my
too.
own brain as well. But the with the neuroplasticity, I'm just wondering, has anyone been using or looking into maybe using psychedelic medicine to help folks who have, neurodegenerative disorders like Alzheimer's or Parkinson's or anything, and any
Mm.
it's on that at all?
Yeah, I know the research. I don't know where it is in the research at a John Hopkins, but I know when they started, I believe they were starting specifically with mental health conditions, but I think their research has gone like they're looking at neurodegenerative. I believe they're looking into Alzheimer's. They're looking at addiction, eating disorders. So it's definitely outside. And just like you named, I know that with the neurodegenerative conditions, I mean, it would make sense. It would make sense if there could be some benefit there because not only again, is there a perceptual allowance of otherness or seeing yourself outside of the constricted way you see yourself? But we know that even with ketamine, there is some brain-derived neurotropic factors, so BDNF amplification. There, I believe, also with mushroom, with psilocybin, both have anti-inflammatory properties. Mushroom can have significant anti-inflammatory properties, and that is happening at the level of the astrocyte, at the brain, synaptic junctions, all the things that we think are cool and learning about neuroplasticity. There's similar properties that are happening with the psychedelic. And I think most potently, what we see is there's an openness. There's a it's a neural flexibility that happens during the experience, sometimes profoundly during the experience. And even when it crystallizes down and people are back here and grounded and feeling more like themselves, they're still open. So it's a really good time to embed in more awareness practices, watching your thoughts, noticing your thoughts. Psychedelics allow us to separate from our thoughts so that we're not our thought, we can recognize that, I as a witness am having a thought. That space is really a common thing that arises when people are working with psychedelic. And that can be itself groundbreaking for people who've never really separated from their own thoughts.
Pretty amazing. Yeah,
It's cool stuff. It's
yeah.
cool stuff,
I can see more and more why you've gone down this pathway.
right? Yeah.
That's pretty
Well,
cool.
I think of all the things that, I'll be just frank and honest. It was through my own experience that gosh, I must do everything the hard way, but I didn't plan to have a really expansive experience of consciousness. It happened through a psychedelic experience. Mine involved LSD. I had no idea what I, had potentially gotten myself into, but it was so profound. Ultimately, it was very challenging, but ultimately extremely beneficial. And yet it was so profound. It had such an impact on me that I, at that point, was like, okay, this is of all the stuff that I'm learning, I have to work in this space.
Mhm.
We have to, and then only to realize that, of course, this has been known for, thousands of years by other people, other healers, other groups. We're late to the game.
With so many things, a lot of the most
Right.
in practice are like, oh yeah, that's, just going back to our roots.
Mhm.
Hippocrates had it all
Right.
figured out, father of medicine. But anyways, um,
This is it.
yeah. One just circling back around for one more second to the neuroplasticity in folks with neurodegenerative conditions. I'm just wondering if you happen to know offhand, like in sort of traditional cultures or like they're in say like indigenous cultures or
Mm.
America or places where we know there's been long-standing use of psychedelics. Do you know offhand if there's any like historical accounts or traditional uses where like, oh yeah, like Grandpa's getting into his 60s or 70s or beyond, and
Right.
starting to
Oh,
starting to go down the hill. I'm just wondering if that's something that's been talked about. 'Cause I just feel like where it's like, oh, we talk about like, brain exercise. Like, I'm going to do a Sudoku. It's like, well, or have like a, expansive, experience like this. Like, man, like what a workout for the brain. Of course there's going to be a
right.
neuroattractive factor. So I'm just curious if there's any kind of traditional use in that you've heard of.
Gosh, I love that question. I don't know the answer to that. I know that in certainly in different cultures, um, they don't have the mental illness lens that we would hold. They don't have recognized depression or anxiety. And if they had folks that are experiencing symptoms of that, I think they would just hold it differently. They would translate it differently. And if people have early psychosis or schizophrenia, then they would think that maybe they're just open to different realms.
Mm.
They're just more multidimensional in their awareness, and at a young age, they would probably hold them differently and teach them differently.
Yeah,
So I know that that can be very different, but it's a really good question on the neurodegenerative. They're also their lifestyles are possibly so different that as that most of I think the neurodegenerative things that we're seeing is this complex expression of probably chronic inflammation,
100%.
and coupled with all kinds of other things, dietary, poor sleep, genetic predisposition probably, but
Mm.
yeah,
Yep. Fair enough. Yeah. Yep. Not as
all
prevalent
the
one
stuff,
time, but
all the stuff
the
we
stuff.
do.
Yep. Okay, one more just random question here before I ask you about the experiential part of it. So just folks listening might be wondering just about microdosing. I know I've had a growing number of patients
Yeah.
who are, accessing one way or another. I don't ask questions; they just tell me what they're doing. But microdosing like different types of mushrooms, and I know there are websites out there where it's like, oh, like microdose this if you're looking for this, or microdose that if you're looking for
Right,
seems to be turning into quite an art form, albeit maybe an informal art form. I'm just wondering,
right.
kind of contrast micro and just to say, like I'd say a majority of the patients who tell me about their microdosing experiences like report it being positive, like
Mhm.
helping with their anxiety or helping them to feel more like socially open, yet not altering their default mode network in a meaningful way so they can still function
Right.
and all these things. Like, I mean, I'm not commenting on whether that's a good idea or not, but just saying this is what they tell me they're doing. So I'm just wondering, yeah, does that fit under the umbrella of psychedelic medicine? I guess maybe technically it does, but where it's not having like a, dissociative type experience. And just wondering how you
Mm.
test that.
Yeah, it's a super question. We actually just started here at the clinic a microdosing group to support people microdosing because so many folks are doing it and there's a lot of questions that arise. And we decided, okay, we can do a harm reduction model, meaning we're not procuring or offering or giving people the psilocybin because of it's not been decrimmed yet, but we can at least offer what we can, surmise now to be our best guess and evidence and how to do things safely. And the truth with microdosing, while there is a growing body of research with macrodoses of psilocybin and the other psychedelics we spoke of, specifically LSD and ketamine, there's not a lot of research on microdosing. The microdosing, only because I just had to review this for my group, so I'm kind of like usually not that much up on all the research, but I've just been reviewing this. And the microdosing research that has been done, there's a lot of, there's inherent bias, there's problems with people, breaking the blind. They take the capsule and it's more than a microdose, and they know they're having an altered state. And so they're reporting back information that, that it's not a truly blinded study. Um, so we don't know. We can't say at this time, honestly, that it is totally safe. Although I would say when psilocybin in larger doses has been studied, it's one of the safest compounds that's ever been studied. Psilocybin tends to be extremely safe in very big doses of a macro dose of mushroom, I should say, if you have a really, really altered state, there can be psychological risk, but I mean pharmacological risk. Psilocybin is very safe. But in the micro doses, we don't really know what it's doing because with the hormetic uh, principle of pharmacology, when things are in very small amounts, they may act differently, and the properties that they have may be a little bit different than when we take a larger amount of a substance, and that's true for pharmaceuticals. So we don't know exactly the same properties if it's having. Most of the evidence for use, it's anecdotal. And yet, just like you name people who are choosing to microdose and they're intentional about it and they do a thing and they have a program they're following, many people report benefit. So that's been studied. People, just asking, okay, what are you doing? Tell us what you're doing. What are your outcomes? How are you microdosing? And that's been informing the research, just kind of collecting what people are doing, and often finding it beneficial. But I would say most people are microdosing for maybe some mental health benefits. There is some evidence around pain reduction. There's connectivity, creativity, more attention. Um, and then there's all kinds of different mushrooms, like you said, on the market. So people can choose which mushroom. But, off label, we encourage for safety for people to probably work with Golden Teacher because it kind of stands true to its name. It's more of a Golden Teacher. They might purchase like a blue meanie, for example, and those mushrooms can be challenging. So
With a name like
know a
that.
little bit about the mushrooms before you order them.
Mhm. Okay. That's very good to know. Thank you for
Yeah.
that info. Um, so as far as the actual psychedelic medicine experience
Mhm.
is like, and I mean, you've already kind of touched on like what it might be like for the person experiencing it, like the
Mhm.
actual psychedelic and induced state, and where it's very hard to articulate it, but using the
Mhm.
questionnaire that you referred to, getting some insight into that. I guess what I'm wondering mostly is like, say a patient, is with you. I understand from our previous correspondences that they'll kind of maybe actually well sorry let's just get right to from square one here. So I think you told me
Okay.
that they'll maybe start with like a lower dose, kind of gradually increase. And so I guess I'm wondering, would you be able to just quickly speak to what that the reported experience is typically like from that? So
Mhm.
what are they experiencing with the lower dosages till they get to the higher dosages? And then I'm also wondering,
Mhm.
like, what are they doing? Like, what is your role during their actual psychedelic experience? Like, are you talking with them? Are you guiding them? And yeah, if you could maybe just riff on that a little bit, that would be great, please.
Sure, that's awesome. And I should say, and I think you'll appreciate this because I'm sure it's similar to the work you're doing, that I see psychedelics as it's a tool. It's a tool. It's a very powerful tool. The whole class is an extremely powerful tool, but it's a tool for people to better understand themselves. And when I think it's beneficial or it may help them is they're already or they're engaging in self-care of, say, they've made dietary changes and they're working through maybe movement and, they're on some supplements, and they're doing breath work and they're doing all kinds of stuff. Most of the folks, both of us that we work with, they're doing the stuff. It's not that they haven't tried the stuff, but they get to a limit. And the limit typically is an unconscious belief strip, like a belief system that they are often not aware of because none of us are aware of them because they're unconscious, is one of the things, or it's deeply patterned behaviors that are so second nature to them, they can't see them. And anyway, these are kind of the folks that end up finding me and are ultimately engaging with psychedelic medicine. So the model that I'm using is a one-to-one model, although I do want to be working more towards a group model because traditional use of plant medicines was always done in community and was always done in group. So there is the connection of the container, there would be the shaman and the assistants, and the community is all together. There is drumming, there's chanting, there's singing, and it's a shared collective experience. That model, unfortunately, has not translated yet into the primary research. So we've I don't want to say over medicalized it, but I understand why it was done. It was medicalized so we could produce information, so we could gain trust in these medicines and push ahead the research. But the medical model is it's different. Typically, clients have a headset on. They're listening to music. The music I use is a group called Wave Paths. It's a web-based, really interesting uh, production platform where they're making all kinds of really interesting music for psychedelic. So they have sound playing. They are wearing an eye shade, so that sensory deprivation is happening. And why again? Because we're so cued by our senses, specifically our visual sense, that if we're looking outside, we're engaging in the otherness and the relative reality around us. When our eyes are closed, we're kind of forced to look inside. It's like the idea that you have to turn your sight or turn your third eye back towards yourself, and then you're more open to receive what's really going on internally, which is usually where all the information is that we'd like folks to explore. So, and this of course is after. So that by the time I'm seeing them for their ketamine session, we've done an intake. It's a full integrative and functional medicine assessment. We're looking at all the things. They're usually having other systems biology, healing and medicines that are on board and practices. And there's preparation for the ketamine. So I want to make it clear they just haven't popped in and let's just do some ketamine, right? And then all the risks is explained and inclusion, exclusion, of course. So the beginning is zero point 0.5 milligrams per kilo. It is a racemic ketamine. It's an intramuscular injection that I've been using. It's about 98 to some studies would say 100% absorbed at that dose. And that dose, people will feel, and again, they're lying down. I have a kind of a cushy situation. There's heated blankets and nice pillows and everything. They're feeling relaxed. Typically, the muscular system is relaxed. There is a sense of letting go. Most people report a sense of safety. They feel very kind of cocooned and held. The music is playing, and the instructions that we offer folks is to follow the music and follow their breath. So the music is very instrumental in the experience. It's pulling them into different phases of emotional spaces. The lower doses, people tend to get a lot of narrative experience. So feelings and imagery about their own personal history, their families. They might have access to people who've passed. They recognize their grandfather is there and they're having an experience. It tends to be very much about their own story. As the doses go up and people they still have a very dissociated, I hope, beautiful experience, but they don't really have a strong sense of their personal story. They either will report being in outer space or they'll be in, a rushing kind of water molecular experience where they're kind of everything being like mishmashed or washed up together. There can be a lot of movement, there can be a lot of vibration, there can just be a lot going on. But the idea that they were having a story, they're kind of past that point. And that can be, some people prefer the lower doses because they actually like the part about their story.
Mhm.
So I always push people to those higher doses. I typically don't use doses higher. Like 1.5 milligrams per kilo is kind of as high as I go. Other clinics do use higher doses. Um, I don't know if it's always beneficial. And I'll put it at that. It may be beneficial. I don't want to say it's not because I still think there's the neuroplastic benefit. There's definitely the modulation benefit, but they won't be able to hold that information in a conscious way.
Mm.
And with the work we're doing, which is a lot on your intention and your observation and really cultivating your conscious awareness, I think it's profitable to stay in that like point. It sounds so specific, but it is like that 0.8 to 1.4 milligrams per kilo. Like it's very specific where things tend to line up for people.
Mhm.
Yeah.
Um,
So
so
does that help? Oh, and I should just say it's like 50 minutes. I should tell you this as well. It's like onset, not even 4 minutes. Peak is around 19 minutes. By 35, 40 minutes, they're coming back. And by 50, 55 minutes, the relationship it's closed off.
okay.
Yeah.
So during the actual experience itself, like the actual like 50-minute experience, like
Yeah.
they're not like you're not actively engaging and like you're not talking to them or like you're there to make sure they're okay, but not actually like giving them guidance or advice or anything. But maybe
Right.
afterwards there's like a debrief or some counseling afterwards or what happens
Yeah.
that way?
It's exactly that. And there's different models. So you can do low dose ketamine and it can be relational that I can give you some ketamine that may be more like 20, 25 milligrams. And then we can sit eyes open and converse. And there is a bit of lubrication that happens. And MDMA is often used that way. Any low dose psychedelic can be used very relationally. But this, no, exactly. They're having an internal experience of their own cosmology, essentially. And we want to encourage that because as soon as we come out and we're talking, we're not really in that relaxed introspective state. And if we have kind of a lot of defenses or we have a lot of maybe apprehension socially, we're not really getting into where we need to get to. So this is an invitation to really go into yourself. I am, right by them. I've trained in my level 1, level 2 Reiki. So I do like very gentle what is it that I do? If I have to describe what I do, I'm essentially sitting in a meditative space that I'm holding a frequency of love, to be honest. I'm just holding a love frequency, like a neutral love tone. that will help them feel supported in their experience. That's kind of what I'm doing. And if they at any point need anything, if they need anything, often people might peek out to make sure that, I'm still there,
Mhm.
right? At the higher doses, they're like, what, wait, what's going on here?
Mhm.
Some people benefit from specific pressure, like maybe just holding a hand, or maybe it's just only, and this is with consent, but it's only very peripheral body touch. Um, Breathing, if anyone gets into a space where they get a little bit like, oh gosh, that was more than I anticipated, we just encourage them to breathe deeply. So it's very supportive, not intrusive, not directive,
Mhm.
because they're in a very open space. So my only role is to make them feel as safe as possible. And then you're right, we after 55 minutes, an hour, we put on some tea and then we integrate for the next hour.
Okay.
Yeah,
And as far as that integration goes, again, I'm sure it's different from patient to
sure.
patient, but it's
Right.
more like just open-ended questions, like so they can kind of like get things like out there in terms of expressing their relating their experience, or like what's the nature of that hour-long conversation?
Sure. Yeah, the beginning is definitely like, tell me about your experience. Now, some people actually, during the experience, I should name, they are narrating the entire time. So even though they have the noise canceling headphones and they've got the eye shades on, it's so profound that they're simply speaking. So when that happens, with their permission, we either record their own voice or I'm recording it. But I find the recording device is easier. Some people will just put out a few words. And if that's the case, I'm recording the words. And so when they're done, it can be like, well, tell me about that magenta color that you were describing, or tell me about what happened when you saw that, your dog or that tree. Like it can be very specific things that come in. And then, so the beginning is just them relaying back their experience. And then typically the information that they're seeing in their experience is just like a dream. It will fade if we don't attend to it, but there's information there that's gold that we try to, like, why do you think that came in? What was significant about that? How did that make you feel? What came into mind when you, even as we're talking about it? And so the idea is that we're trying to pull that information in to make it relative to what's happening to them right now.
Mhm.
Right. Again, with the naming the limiting belief systems and the subconscious programming, it can be aspects of their shadow self or their unconscious self that they just haven't been able to access. And all of a sudden they can see something. They can see it. They can see that they've been really harsh with themselves, or that they've been holding themselves to a really high standard that is causing them distress, or they just have an increased awareness about it. And then the real integration is remembering that. And then in the future, and there's a lot of homework and a lot of little tasks that we offer, but when you have that thought come back, because you will, it's noticing the thought, with compassion, noticing it and taking usually 3 breaths. That's the neuroplasticity of trying to uncouple from the pattern. And then that is really the first 72 hours after ketamine is when most of that work is happening, if that makes sense.
It does, yeah.
Yeah.
And I don't know, just kind of clinically curious here, like in terms of the
Yeah.
subconscious belief systems or the ingrained behaviors that they're just not aware of. Like, what are some of the are there common themes that come up? And if so,
Oh,
what are the common themes?
oh gosh, it's so poignant because the human experience is so challenging, but there's such a lack of self-love. There's
Mm,
such a there is such an epidemic of over um, over expressing your energy to otherness and giving all of your resources out, and then self-deficiency, feeling not enough, feeling incomplete, feeling like something's wrong, like something is fundamentally wrong with them. And somehow everybody else has this thing figured out called life, and they're the ones that, like, that I hear all the time. And I have the benefit of hearing it. So I can reflect back that you're in really good company, because every single person that I work with has a variation of those themes, right? So I would call it, yeah, it's like a love deficiency, a self-love deficiency. Most people. It's usually learned early on. It is a habit that it's so long standing. They haven't really looked at it. They haven't recognized that it's even a thing. And it can express itself in many different ways. But typically, yeah, the not enoughness. But also things like, life is hard, or I mean, life is hard. Let's face it, life is challenging, but that the fact that we feel powerless in it is a limiting belief. But we learn that limiting belief because we were in environments that we were powerless in, right? So that's a common one. Yeah, a lot around finding your own power, remembering your sacredness, that we're not separate. I mean, the most common belief is that we're separate,
Mm,
right? That is the most isolating common human belief, is that somehow we're separate. Somehow everything in nature is somehow doing this connected thing, and the human is separate, but that separateness is causing deep pathology for all of us.
mm. Um, Once again, as you're talking, Dr. Goth, I'm thinking of more and more questions, and I know our time is winding down, but I've got to
Sure.
skin one more here because I'm just really curious.
Yeah.
Have you noticed any difference, like between, like, say, again, I hear everything you're saying there, a lot of shared experiences that makes a lot of
Hmm.
sense. What I hear and perceive by proxy, with my patients not doing psychedelic medicine with them, that makes all the sense in the world. I'm just wondering, have you
Yeah.
noticed a difference between, like, say, different genders or like generational differences, like folks that are in their 60s versus their 30s, like, and if so, like, could you briefly comment on that? Because I'd be very curious.
Yeah. I can generalize a few things. I would say women, kind of XX women, tend to be more open, and they tend to require smaller doses. Now, that's also could be a body weight thing. So there might be a confounder there, but I find that women are more open to connectivity anyway, and so they can drop in maybe a bit more readily. Men may not have that. I mean, I don't want to sound like the wrong thing or say the wrong thing, but in my experience, they tend to need bigger doses and maybe more, maybe a bit longer. A lot also depending on their personal history. Again, if there's a really strong control and protection because of a trauma, that protection was necessary for themselves and got set up to genuinely protect themselves. So sometimes that's not always an easy thing to get past. And if I anticipate that with somebody, to be honest, they may not be the best candidate for ketamine.
Hmm.
They may do well with low dose ketamine relational. They'll probably do best with MDMA and or these other modalities, because I don't believe that everybody needs to lose and dissolve their ego. Some people do, and yes, it can be extremely beneficial, but it can be, a really challenging experience. So it's not again, that ego dissolution, when we see that in the literature, it tends to um be with the mystical experience. There's a lot of benefit, but you can get benefit without, losing entirely your sense of self. It does come back. I should let people know it comes back. It's not like you lose your ego. It's like, oh, I'm egoless. No, it comes back like in an hour. But
Hmm.
when it's out, it can be something. It can be a really different experience for people.
Hmm. So maybe just one final question here, just I feel like to kind of wrap things up here,
Sure.
or tie it all together, I should say, for folks. So they have the psychedelic, work with the psychedelic medicine, they have these experiences, will person learns about some of the subconscious belief systems, like those percolate to the conscious level, and then they get this insight, and you're there to guide them, and to not forget about it like it was a dream or something like
Mhm.
that. And then kind of moving forward, is it the type of thing where folks will say, like, oh yeah, like when now I recognize, like, okay, I need to work on the self-love, or I need to work on the, recognizing our interconnectedness, or whatever it happens to be. And then by starting to integrate that, then they'll report, I have less depression, anxiety, less, I don't feel as, like, adrift at sea and not sure what to do with my life, or like what are some of the kind of like the longer term, or maybe like medium to longer term outcomes that you've seen from the psychedelic medicine?
Sure, sure. And yeah, it's exactly that. I think especially even like we haven't talked about like the big doses of psilocybin and mushroom, but those can be and I would say probably more than ketamine. It can be like a life altering, like it's such a departure or such a shift of consciousness. And like you named it, it's that sense of intimate connectivity that people can remember, and not just like me telling them, you'll feel connected. They know in every cell of their being that they're intimately connected with everything else. So if you've gone into that experience with a sense of isolation or fear or hypervigilance because you feel alone and you have been alone in your life, and all these things that get set up through childhood and maybe a challenging life circumstances, if you then have a first person direct experience that you are interwoven and interconnected with all things including the divine, like, and then you come out of that experience, like that's a hard thing to unsee and unfeel.
Mm,
And then the work is then integrating, okay, what does that mean if I am part of everything? Typically they feel better. And usually the beliefs they held about themselves have just they fall. Now, if we don't practice though the new way of being, then we can fall into old habits. We certainly can, usually under stress. It can be like the way that we were before can come back online. So again, the integration work, we try to, we think of behavior change models, anywhere from 8 to 12 weeks. We try to map this out for folks to maintain the new neuroplasticity of the behavior change, but remind them that really it's essential to be in communities where people are maybe feeling the same way, and maybe they are talking about interconnectivity, and maybe they are having more nature-based experiences. And that's another way of keeping it open versus going back to maybe the same mode that they were in. Typically people, because of these shifts, actually do make new connections, and they may feel less relatable to ways of being that they were in before too.
mhm.
Yeah.
That makes a lot of sense. Well, it's really fascinating, Dr. Goth, and thank you so much for sharing your experience with us. And yeah, really thankful to have you just really down the road from us. So, easy referral. And I know there's folks, growing number of clinicians, I think, like yourself, offering these therapies. Although, as I said in the intro, I pre-recorded before we started talking, but you're a very special clinician, and I think folks able to work with you directly, very, very fortunate to have that opportunity. So thanks for doing what you do. Um, I just before I ask you to share how folks can get in, find you on social media or contact you, I did forget to mention earlier in the chat, just for folks listening, as per usual, nothing we talk about on this podcast should be construed as medical advice. This is for information purposes only. If you need healthcare advice, please talk to your healthcare provider to get that advice. And on with that out of the way, Dr. Goth, would you mind just sharing like your website, social media, wherever any online offerings you have, please?
Awesome. Thank you. And thank you so much, Brian, for your work that you do. And we've shared clients for many years. And again, they're just so fortunate to work with you, and you offer
Thank you.
so much to them. And I've been able to witness it from that side. So yeah, so much gratitude for the work you're doing. Right. Okay. So my website right now, it's being reconstructed soon, but it's just www.dralexisgoth.com. We are on Instagram under Holos Integrative Health. The clinic is called Holos, Holos Integrative Health, and also on Facebook. People can self-refer to the clinic. The model is a hybrid model. I should mention that we're trying to do what we can through MSI. And so the prep work and the integration aspects around the psychedelic are right now, we're using the counseling codes and some of the psychotherapy codes under the provincial healthcare plan. But the medicine itself, the ketamine itself, is a private pay, so that is not under MSI. But Alberta just passed Blue Cross just approved psychedelic assisted medicine in Alberta.
Hmm,
So hopefully there may be some opening for third-party insurance payment in the East Coast.
cool.
Mm.
Good stuff.
We do suggest, though, that you get a physician referral if possible, mostly because we want to translate all this information back to primary care, back to potentially a psychiatrist or a chronic pain specialist. So we like that other physicians know what we're doing, but we understand that many patients don't have a primary care physician, so they can self-refer.
Perfect. Great. Well, I'll put the links to the Instagram page and your website in the show notes for the episode or in the description of the video on the YouTube channel. And yeah, thank you so much again, Dr. Goth. Really appreciate your time today. It was a pleasure.
Thank you. Thanks so much.
And thanks so much for everyone for listening to this episode of the Overcoming Chronic Illness podcast. We hope you enjoyed it, and please stay tuned for the next one.